Let's start. So I'm Rémi Rabasa. I am an endocrinologist and clinical researcher in Montreal. And I have the privilege to make that presentation tonight around hypoglycemia to try to discuss how much this is an important problem. All along the presentation, which will last around 35 minutes, you can ask your question in the chat, in the Q&A question. Some members of the team are here with me to help to answer to it. And at the end, I will open the chat box and try to answer to as much questions as possible. So what are we going to discuss tonight? About the different levels of hypoglycemia, which thresholds are associated with what kind of problems, the consequences of hypoglycemia, and all what we can do in terms of training and technological tools or different insulins that can help to reduce the burden of hypoglycemia. So a lot of the data I will present tonight is coming from the BETTER Registry, and I will make a slightly longer presentation, a BETTER Registry in a few slides, but it's a registry built by patients, which currently we have mostly data from Quebec, more than 2,700 patients, but we are just open to the rest of Canada, and we just had close to 200 patients joining in the last week. So in the BETTER Registry, based on numbers reflecting mostly patients from Quebec, we have actually close to 80% of the patients reporting that at least one time in the month, they went as low as 3.0 millimoles, which is considered as a serious hypoglycemic episode, serious in the sense that it could lead to more severe hypoglycemia that we'll discuss later. What is extremely interesting is that the patient reporting at least one episode below 3 is not only reporting at 1, they are reporting close to 2 per week, because it's very close to 8 episodes every month. So what is the BETTER Registry? It's a registry which is kind of a census which was co-built between healthcare professionals like me, but not only me, and patients to try to answer to questions that cannot be answered in big database, like, for example, in Quebec, the RAMQ database. So there's a lot of questionnaire in BETTER related to how people feel and how the people react and act around their diabetes, with a main focus on hypoglycemia, but not only hypoglycemia. Everyone who wish can join. It's on a voluntary basis, and it is done by any patient himself, herself. If she is above age 14, below, it's by the caregiver that the answer is given. And we are extremely proud now to be able to present to you quite a lot of data tonight. It's only going to be a glimpse on what is in the registry, and we hope it will speak to you on what is related to hypoglycemia for people living with type 1 diabetes and their relatives. So we will speak a bit about definition. We will speak about causes, some of them being under the radar, and consequences, and then we will switch to how to reduce this and how to treat some residual episodes if we are not able to prevent all of them. So hypoglycemia for people living with type 1 diabetes, this is not a definition that would apply to people without diabetes, is any blood sugar below 4.0 millimoles, and it can depend on numerous factors. For example, the length of diabetes. Usually there will be less symptoms with time, and a major factor is the frequency of hypoglycemia. The more one would do living with type 1 would do hypoglycemia, the less she will have symptoms, and those symptoms will usually appear at a lower threshold than earlier. Some other circumstances, like important alcohol consumption, I'm not speaking about a glass of wine listening to that webinar, but rather 3 or more glasses of wine, which can hidden some symptoms of hypoglycemia and increase the risk at the same time, not only because of the symptoms, or some situation like physical activities where the symptoms are hard to assess, because some of the most frequent symptoms of hypoglycemia can be sweatings and heart palpitations, which obviously you can have during physical activities. The symptoms can vary enormously from one patient to another, from one episode to another, and sometimes they can be without symptoms, either because the patient have unfortunately completely lost those symptoms, or because the symptoms occur at night, where we know now that close to 80% of the nocturnal hypoglycemia episode can be asymptomatic. How do we treat a hypoglycemic episode? We need to measure blood glucose. It can be done now with most of the glucose continuous monitoring system, which in the BETTER Registry are used by approximately 80% of the patients. But we know that in some centers, it is now close to 95% of the patient using this, but so it can be diagnosed with a capillary blood glucose. In some circumstances, even if you have a sensor, it might be useful to confirm this. If you feel that it should not be in hypoglycemia, it can be important to confirm in some rare situations. Obviously, if you have capillary blood glucose, you should confirm this. Then eat without waiting fast-acting carbohydrate. The most frequent one used are, for example, in the Quebec milieu, Dexport pills, but there are other things. You can have your other favorite way to do it with some candies or whatever. You can use like jam, for example. It's possible. The current rule, and you'll see further in the webinar that we will challenge this, is to take around 15 grams of carbohydrate and wait 15 minutes to treat yourself. And then after 15 minutes, you need to recheck this. If you're using a continuous glucose monitor, there are two main on the market in Quebec, the Abbott Freestyle Libre and the Dexcom G6. You need to really check. And remember that a sensor is, when there is rapid glucose fluctuation, is always late compared to capillary blood glucose. The two are not measuring the same thing at the same time. There's always a little delay between the two. So the important thing is to realize that when blood glucose is going down rapidly, the sensor will go also down with some delay. So if the sensor is indicating that you are 4.2 decreasing rapidly, you are probably already below 4 actually. So always remember that the sensor, there is a slight delay. And obviously, we should try every time to identify the cause to try to prevent the recurrence of hypoglycemia. So what happened about more severe episode, the one where you absolutely need a third party or you would lose conscience? Unfortunately, this is reported in the BETTER Registry by approximately 13% of the patients. It's quite similar to what was reported in the US. Another thing which is quite similar is that smaller group, fortunately, of patients that had at least one episode, as a mean, actually had two. Actually, the main risk factor, the main condition increasing tremendously the risk of having a severe hypoglycemia is that if you had a recent episode. Another important risk factor is to have less symptoms or no symptoms, or symptoms occurring at a far lower level, what we call impaired awareness of hypoglycemia. And it's approximately 1 patient on 5 in the BETTER Registry reporting those kinds of lower perception or no perception of hypoglycemia. So severe hypoglycemia, the actual medical definition, and we know that healthcare professionals don't always give the entire definition and sometimes ask the question in various ways, which is not a good way to do it. It's a hypoglycemic episode requiring assistance of another person, or the use of glucagon, or hospitalization, or loss of consciousness. And actually, the sentence is even longer, and it's saying that it would be some cognitive dysfunction. So as I told you at the beginning, the BETTER Registry was co-developed by patients, and those patients criticized tremendously that definition. So at one extreme, they said that cognitive dysfunction for them is an equivalent of dementia, which is not clearly the case in medical terms, and that it's for them a permanent situation, which is not the case neither. At the opposite, they said the intervention of a third person, this is extremely subjective, because if I'm on my sofa and I ask to my life partner, to my kids, or anyone sharing the evening with me to bring me a glass of blue juice, this would be by definition for you severe hypoglycemia, which is not. So we worked with them and they came with a simpler definition, which is a low blood glucose that I would have been unable to treat myself. And this has been now validated and published. I will try to explain you what is actually published or what is earlier data. So when it's published, it has been peer reviewed, and this is always far stronger than earlier data. And we have now validated that simple definition that ensures common understanding is actually measuring exactly what we awaited, which is exactly the same relationship for risk factors. For example, the people that have a perception of hypoglycemia symptoms far lower are unfortunately exposed to a far higher risk of hypoglycemia. And every time we measured this, it was exactly the same relationship with risk factors, which is exactly what you want scientifically, to be sure that you measure the same thing with a slightly less frequency by the simpler definition of patient, because actually we probably only capture real, true hypoglycemic, severe hypoglycemic episode, and not the one that the patient would have been able to treat on him or herself. So we strongly suggest now to the healthcare professional that they should ask about low blood sugar that the patient would have been unable to treat himself. Obviously, the intervention of a third party, if you're unconscious, is one of this, but the intervention of a third party in other circumstances might not correspond to a severe hypoglycemic episode, and this is not appropriate in our opinion. What treatment? In most of the case, and around 90% of the case in the BETTER Registry for severe hypoglycemia, the patient will use oral carbohydrate to treat the episode, and this is absolutely perfect. However, when the patient is unable to drink or eat, either because he is obviously unconscious, or you try to help a person living with type 1 diabetes, and then coughing up air, meaning that actually part of what was just eaten or drunk is directly in the lungs and not in the stomach, you should go to glucagon. The BETTER Registry numbers show that actually 20% of patients living with type 1 in Quebec have never been prescribed glucagon, which is not a good thing. Glucagon is actually the kind of EpiPen of the severe hypoglycemia. It can treat very rapidly. There are two forms of glucagon, an old one, which is on the market for the long time, which is a powder and a liquid and a syringe, and you need to take the liquid to the powder and so on, and then inject it. And it's really not appreciated by a lot of patients. There is a new format of glucagon, which is the Baqsimi. It's a nasal powder. It's easier to give, far easier, far more rapid to give, and it works nearly all the time exactly as the injectable glucagon. It is extremely well covered by RAMQ. So we think that people need to be aware that this exists. Obviously, we hope it will not be used and then become past the date of usage, which, by the way, is twice longer than the older form of glucagon. So it's really an improved version, which is giving the same results as the old glucagon and should be more available and used. Then we have developed in the BETTER Registry, and like for the inscription, you can also scan with your cell phone, take a picture of that QR code. We have developed lists of most frequent causes of hypoglycemia, too high or too low, to help patients, if needed, to have a reflection on causal factors, which is probably the most important, and they are so numerous that I will not go in details around this. What are the potential consequences? Here, I need to pause to say that some of them are going to be direct causal relationship, but the three that here are more association than causal relationship. So an association is two things that happen at the same time. Doesn't mean they're directly related. To take an example, we regularly use at Faculty of Medicine, people tend to die, unfortunately, in a bed. Doesn't mean that the bed, so dying and being in a bed are associated. Doesn't mean that the bed is directly responsible of someone dying. So a good example for this is cognitive decline. Obviously, when you're very low, you're not very bright, This is normal. Glucose is a main source of energy for the brain. But does recurrent hypoglycemia cause cognitive decline, memory problems? It is possible. There is no demonstration that there is a direct relationship. So it remains only possible, and that's an unpleasant question. However, hyperglycemia, the chronic one, the chronic high blood sugar, have shown to have some results there. It's a bit the same for cardiovascular problems. We know that low blood sugar can expose the patient to a more higher risk of heart rate problems. And we know that on some very rare circumstances, those heart rate problems go to the heart that stops to beat. So obviously, on rare circumstances, hypoglycemia can kill people. It is very, very infrequent, and a more general, broad sense of the terms, cardiovascular problems, possible, not sure. Again, associations with what we call endothelial dysfunction, which is the first early stage of what we call atherosclerosis, that process that can go to the occlusion of a vessel. So the problem here is the chicken and the egg. And to go back, for example, to the cognitive dysfunction, you can imagine that someone that would have, for example, memory problems for another reason than type 1 diabetes could make some errors in his treatment. For example, take insulin and forget to eat, or take twice his insulin. And this then hypoglycemia happened because of the memory problem. It is not the cause of memory problem. So here again, very thing that can be very worrisome, but it seems to be at this point more, how could I say, association than causal things. However, which has been far more explored and well established in type 1 diabetes, recurrent hypoglycemia is associated with a less good quality of life. It can be associated with fear and anxiety, for example, fear of hypoglycemia, which can really reduce tremendously the quality of life of people living with type 1 diabetes. It obviously can interfere with daylight activities, for example, canceling going to the theater, or canceling a sport event, going biking, and things like that. And it can also be associated with decreased productivity. So what we are studying in the BETTER Registry, and this has already been presented in Congress, so it has gone through a simpler peer review than a formal publication, and the manuscript is in its final phase to be submitted, so it's a bit less strong in terms of scientific validity and rigorousness than what I've already showed before. And we can see that, and you will have always on the left of your slide the level at 3 millimoles, what we call serious hypoglycemia or level 2 hypoglycemia, and then on the right, severe hypoglycemia, the one that you would not have been able to treat on yourself, that you would need help for that. So if you look at the top of it, you can see that most patients would monitor their blood glucose more frequently, 40% in serious hypoglycemia, around 50%, a bit more than 50% in severe hypoglycemia. It could have been more, in my opinion, but maybe because a lot of patients now with continuous glucose monitors already check a lot their blood sugar. At the bottom of it, you see something that is probably less desirable, though understandable, that some patients consume more carbohydrates. And we now know in the BETTER Registry that around 60% of the patients living with type 1 diabetes have some degree of weight excess, what we call overweight or obesity. And it could be a cause for this. So it could not be desirable for this. So it's perfectly understandable. And you can see that approximately between 1 on 3 and 1 on 4 patients adjust at least one insulin. We could have awaited this a bit more, but what is in the BETTER Registry here has been already reported, and the numbers are slightly different, but nothing that is really getting completely different from what is known. However, what has been a bit less reported, but still there are some publications, is what we call the use of healthcare services. To what extent people that had a hypoglycemia would need more consultation or more emergency services. And you can see that severe hypoglycemia, which for people living with type 2, the most frequent form of diabetes, usually lead to the hospital and to medical consultation. Well, people living with type 1 know how to handle those episodes. Doesn't mean it's not traumatic, doesn't mean it's not dramatic, but they they are able to reduce tremendously compared to type 2 diabetes, the need to go to the emergency or to have the paramedic coming at home. However, to my big surprise, only 40% of the patient will discuss that kind of episode at the next medical appointment. It should be 100%. Actually, a very good study in Ontario have shown that discussing with the team offered the opportunity to change the treatment or to propose strategies and reduce by half the risk of recurrent severe hypoglycemia. So it's really infrequent. What have up to now not been reported in the medical literature are very, very, very few, and not at the level we are going to be able to do this on more than 2,000 patients, is some of the consequences like persistent fatigue. If you look close, a bit more than one patient on 4 in with level 3 and one patient on 3 at the level of severe hypoglycemia report persistent fatigue. I want to recall you that at the very beginning of the webinar, I explained that in the BETTER Registry, over close to 80% of the patients report close to 8 episodes per month of level at 3, which means 8 occasions of persistent fatigue, which is largely underestimated by a lot of persons, healthcare professionals, but also payers for insurance. When they say this new insulin or this new technological device is too expensive, they underestimate this. And I also want to highlight what is at the bottom right of the slide, is that close to one patient on 3 think that they have shame, they are really annoyed to have this. So it might explain that sometimes it's not discussed at the medical visit, because the patient think that she failed rather than trying to seek help to improve this. And there might be other reasons also for not discussing it at the medical visit. For example, the fear of losing driver license, which has been reportedly repeated in the medical literature. So we are in the phase of preparing this manuscript, and we have already reported this in Congress. So we have done other things. So for example, we have a manuscript, which is what we call under review. So it has been submitted and the peers are now looking to it. And we look to the fact that if people are eating as a mean less carbohydrate in their general diet, do they tend to do more hypoglycemia? The answer is no. We have published in a very prestigious medical journals that the approach to reduce physical activity, exercise induced or associated hypoglycemia when you go running or doing any kind of physical activity, there is a high risk of hypoglycemia. You have 2 big means to reduce that risk, either reducing the insulin preemptively before the fact, or taking carbohydrate at the time of physical activity, and it's or. But we really showed that there is a gender and sex difference in the approach to this, that the male are less reluctant to take a snack, where women largely prefer the reduction of insulin doses. We have also started to explore the stigma associated with type 1 diabetes. We have published a paper outside of the BETTER Registry recently. The team have published a paper showing how much in movies and series, people, the actors that are representing someone living with type 1 are usually represented in a very bad fashion, and hypoglycemia is very, very frequently associated with this. But in the BETTER Registry, we have very good data showing that a hypoglycemic episode is unfortunately a cause of stigmatization, or the perception that the person living with type 1 have that she is stigmatized because of that episode, that she don't take care well of his diabetes. He is not a good patient, which is obviously wrong. Don't get me wrong here. So how can we prevent those episodes or reduce the risk of those episodes? So we have developed an online self-training tool that allow patients to go on that tool and to go and train. This tool was, again, like the BETTER Registry, co-developed by patients and healthcare professionals. It's called the support platform. This is fully available both in French and English. And it has 6 big categories like medication, for example, how to manage hypo and hyperglycemia. And we have 3 versions of this. One is the classical support, and we started with this one, but then realized that there was a big need to develop other things. So, for example, the younger patient, that the one that we call in transition, the one that are in the last years in the pediatrics or the early years in the adult care, wanted a slightly different version. They told us that the version was a bit too much for older people like me. And for example, they ask more detailed questions about alcohol and diabetes than what was asked by older patients. And we also developed a version for the healthcare professionals that are less exposed to patients with type 1 diabetes. And we know that in some regions, the services for type 1 diabetes are very, very low. So this is the version for a healthcare professional that is probably less exposed, like me, to a lot of patients living with type 1 to increase their confidence to better deliver care to those patients. And actually, for the classical support version, we do have the results, and the manuscript was actually accepted very, very recently. It was extremely well rated by the patients. They love the feature. For example, the older patients of my age like the fact that they could have, after a little training, a PDF that they could have in their whatever electronic device with the key point of the learning, and for example, the checklist when you travel and what you need, and so on and so on, or the correction factor, how to calculate the way to calculate how much 1 unit of insulin will likely reduce your blood sugar by how much millimoles, and so on and so on. And you won't be surprised that the younger ones preferred the low videos, and they said it was easy and accessible because it was 24/7 and so on and so on, that they could have a personalized pathway to go to what is directly important for them and not being imposed, and so on and so on. So roughly, it is extremely well evaluated. But the nice news about this is that it also reduced hypoglycemia. There is less reported hypoglycemia. The number of patients that have an important fear of hypoglycemia was divided close by 50% by 2, and they are more confident to treat the results. So we are preparing the manuscript to submit it because we believe that's an efficient way to complement the care that a patient living with type 1 can have with his or her team. Now, about tools. Beside all the new insulins, the big news of those recent years is all those continuous glucose monitoring, which in our milieu in Quebec now, and in other, and for some other provinces also, is well covered. And those continuous glucose monitoring can have alarms. There is still one without alarm on the market, and there are 2 with alarms on the market, and actually a third one with alarm, which is far less easier accessible. Alarms can help to prevent hypoglycemia. This has been repeatedly demonstrated. However, too much alarm is probably as bad as no alarm. And always remember about that delay between what is measured under the skin and what is measured at as a capillary blood glucose. It gives you the full picture and the trend, but it is always a bit late, specifically when blood glucose vary rapidly. So a 4.2 rapidly going down on a sensor is already below 4 in capillary blood glucose. So always keep in the head that there is a slight delay. It's un peu en retard, as we would say in French. The other thing, it can give the big picture of the glucose control over the last 14 days. And there is really, we really advise or recommend or encourage you to go and see your report at least 1 per month, ideally twice per month. And the ideal glucose control, the goal is to have what we call the timing range, which is the blood glucose between 4 and 10 millimoles at 70% or more, because this will give an A1C, which is the biomarker that should be done every 3 to 4 or 5 months in type 1 diabetes below 7%. And because why we want this, because at that level, it has been shown there is no risk of either occurrence or progression of complication like the eye, the kidneys, or the nerve. At the same time, we are aiming to try to have less than 4% of time in hypoglycemia. 1% of time of the day is 15 minutes, so 4% of the time is less than 1 hour in hypoglycemia. And you also have the ambulatory glucose profile, that would say where you're high and where you're low, when it varies a lot and where it varies far less. Sorry. Another big advance in those recent years is artificial pancreas, those pumps that are connected to a sensor and to an intelligent algorithm that will adjust insulin. So, for example, the sensor detects that the glucose is going down, then the pump is going to inject less insulin, and eventually stop insulin. Again, because there is a sensor, there's a risk of alarm fatigue, and there is also, in the addition here, sometimes the system kick off the automatic mode because the things are not happening as planned by the software. Any generation is bringing a tremendous improvement, and you have also the same problem with the slight delay between the interstitial blood glucose detected by the sensor and the actual capillary blood glucose. And there's a lot of discussion on how to treat hypoglycemia in terms of amount of carbohydrate that should be taken to treat a hypoglycemic episode. What research are ongoing, and I'm here speaking research in the BETTER milieu, the teams that are physically in Quebec, though the registry has recently expanded to the entire Canada. Most of the trial directly with physical contacts of the patients are done in Quebec at this point. We will have other sites relatively shortly in Alberta and Ontario for some trials. So we are trying to better understand around the 15 gram, 15 minutes rule, and I will come back in more details in the next slides about this. They are already the Baqsimi that I described, the little nasal spray to treat a severe hypoglycemic episode that you would not be able to treat with oral carbohydrate, but it's coming with pens with already diluted glucagon that would allow to do far smaller dose. So Baqsimi and the traditional glucagon, it's literally an atomic bomb to re-increase blood sugar. And a lot of patients are asking for a more prudent or less intense way to bring back the blood sugar. And also it's hoped that with those little pens, it will be more predictable and maybe more rapid. Also, we already have those insulin pumps that adjust automatically the basal with only insulin, but some of those pumps are developed to also have a little dose of glucagon that would help to further prevent hypoglycemic episode, at least on the short terms. And in high-risk situation, our team and the team in McGill, for example, for the one that are working in Quebec, have shown that this works well and that it's indeed further reduce hypoglycemia. Will the price to pay to have a second hormone, a bit slightly more complex pump, justify that benefit is not yet there. And finally, when people, despite all what we can propose now, specialized care, technology, the most advanced insulin, support from the team, and so on and so on, a small fraction of the patient, unfortunately, despite all of this, do recurrent comas, severe hypoglycemia leading to comas and sometimes to seizure. Those patients up to recently and available in some Canadian centers like Edmonton, Montreal, Toronto, we were able to send them for an islet graft. So the islet is those cells that used to produce insulin that were destroyed by the autoimmune process. But to do this, a bit like when you need to do a graft of a kidney, a heart, or liver, you need that someone die, get back those islets and inject it into a patient that is compatible with those islets. And that patient needs still to take anti-rejection therapies, which have their own problems. But it's a tremendous improvement for those patients. What is ongoing as a research in a few centers in Canada is a trial doing exactly the same thing, the islet graft, but we don't have to wait any more than someone died that is compatible. Those grafts are produced in a factory and we can inject them into the patient. It is still a research, but it's an extremely promising research that we might be able not to wait that someone died, but to be able to propose the graft in a well-prepared patient, not in an emergency like we're used to do. At least in Montreal, the study is really about to start, and it will focus on patients with recurrent severe hypoglycemia. What about the 15 gram, 15-minute rules? So we did a few studies around this showing that the mean patient in Quebec is not taking 15 grams. She is taking a bit more than 30 grams at the beginning. at the first episode, at least 2/3 of the patients were doing like this, and we were unable to show any side effect beyond the fact that it's probably not good to take recurrent glucose like this. The second study we did was to check if it was actually as described in the 1980s, that when you were taking 15 grams, you were increasing your blood sugar by a mean of 1 to 1.5 millimole over 15 minutes. And this was sufficient to bring back your blood sugar above 4, because most patients were treating themselves around between 3 and 3.5 millimoles. So the next study we did was to show that actually in the current treatment environment, it was probably closer to 25 to 30 minutes to go above. So in that study, which is actually submitted for publication, so the peers are now looking to our data, so it's a bit less rigorous to some of the things that I present to you earlier. We brought back very brave patients, a bit more than 30 patients came to the research centers, and we put them voluntarily in hypoglycemia 4 times. Twice we let them go slightly below 3.5, and twice we let them go below 3.0. And in each situation, one we gave 16 grams, and another times we gave 32 grams. And you can see from that graph that contrary to our hypothesis, 32 grams did a bit better at the higher level of hypoglycemia than the lower level. But you can also see that the number of patients that were able to get out of hypoglycemia in 15 minutes is far less than what was reported in the 1980s. So what we are actually showing, and it's not as positive as we thought, what we showed is that the time to get out of hypoglycemia is longer than previously reported. Maybe 32 grams can be allowed in some circumstances. And actually, the main message of the paper we wrote is that healthcare professionals should not blame patients taking more carbohydrate. We didn't see a lot of what we call overshoot hypoglycemia following a hypoglycemia. What we assured that the 15 gram, 15 minutes rules should be revised, individualized, and that we should do better, but we are struggling to find the best way to do it. We are just about to complete a study where in case of eminent hypoglycemia, we tested if taking 15 grams before reaching the 4 could be positive, and we should have the result of that study for Christmas. And the early results from when I'm looking one test and after the other seems to show that in case of imminent hypoglycemia, not waiting to go below 4, as Diabetes Canada is advising, might be a very good idea. So what is coming now? We will have a surprise for the Better group around Christmas. It's the time of Christmas gift, and we will be able to give you a little surprise. It's about to come. We have regular webinars, usually close to 1 per month. The one in December will be timely, if I could say. How do I manage a bit more alcohol during the Christmas time eventually? And it will be given this. Big unmet need in type 1 diabetes. In January, we'll have someone coming to speak about all the joint problems, the problem that can have in the hands. For example, there is more frequent trigger finger, or the shoulder problems that are there, and the little lumps that when you inject too frequently in a certain place, lipodystrophy, would be the one of February, when we will be all full of snow. We will now take the question and answers. Again, if you want to register, or if that webinar has convinced you that giving us a bit of your time answering to questions online is something interesting for you, please do so by scanning the QR code that is there. There is 3 levels of involvement, going from a few minutes to close to a bit more than an hour in the entire. And now, please ask your question in the Q&A, and awaiting the first question, because we just delivered this already in French. I will bring back some of the questions that were asked in French. So, for example, we had a lot of questions about the recent transition that were done for Quebec, people living in Quebec, a lot from classical original insulin like Novorapid or Humalog to biosimilars. For example, Novorapid has been replaced by Trurapi, and Humalog has been replaced by Admelog. And some people were complaining that they were feeling that those copies, those generic, what we call biosimilar insulin, cheaper insulin, sorry, I changed it rapidly, cheaper insulin were less efficient. And the answer to this is, as a mean, those copies are 99.9% similar to the original. There is no difference. This does not exclude that some patients do have less good response to one to another. So in some patients, it's really interesting to test another biosimilar and so on. And there's free rapid insulin available and reimbursed by all insurance and RAMQ in Quebec. There was also a lot of questions about why do sometimes I have less symptoms of hypoglycemia. A lot of things is to do by the speed of the decrease. You would have more symptoms usually when you decrease rapidly versus if you decrease slowly. But again, as I mentioned during the webinar, they are if you do a lot of hypoglycemia, then the symptoms will appear lower, and the limit between the symptoms appearance and the time the brain is not able to react well, and then you might be at risk of not being able to treat yourself, is appearing lower, and you're losing your ability to treat preemptively this kind of thing. We also had a lot of questions how to prevent hypoglycemia during physical activity. Roughly, it is to try to be at the level where you have the low circulating insulin. For those having a pump, it would be insulin on board, which is a proxy of that. So that's one rule, but it's not always possible. For example, you take your breakfast and then you have active transportation to go to the work, and then so it's more reducing insulin when you know that you're going to have physical activity, and then taking carbohydrate if you have not preemptively reduced your insulin, or if this was not sufficient and you see some trends going down. I'm trying to recall some of the other questions. I will look now if there are some questions in the chat. Not yet. So we had a lot of questions from the Francophone group, so please don't be shy. Even if my English is not perfect, I will try to answer this. There was a lot of questions about Baqsimi. Is there some side effect? Actually, there's a lot of side effect of severe hypoglycemia, but we must acknowledge that the only thing that Baqsimi is different from injectable glucagon has been shown similar in the time to get out of hypoglycemia. It has been shown similar to treat even if you have a flu and you have the nose that is not completely clean and so on and so on. It has been shown to be far easier to use, far faster to use. On the dark side of it, it has shown a bit more of headache. This has been shown. Headache also happens when you do severe hypoglycemia, but it has also been shown that Baqsimi tend to do this a bit more. I am trying to recall all the other questions because we had probably over 30 questions by the other teams. There was a lot of questions also about what level the alarm should be set up for to prevent hypoglycemia. This is really patient dependent. If you have a lot of fear of hypoglycemia, you're probably better to have an alarm around 4.5. If you have very low fear of hypoglycemia, it's probably acceptable to be 3.8. And the level of hypoglycemia alarm might also be different between the day and the night. So it's really extremely circumstance depending. And you could probably have a higher threshold when you're driving to prevent any hypoglycemia that could be an additional cause from anything else of car accident. So it's really depending on the risk of severe hypoglycemia and your personal relationship to hypoglycemia, which might change from time to time. My God, you have no question. I never saw this. Please ask questions. Don't be shy. I'm not sure I can answer to everything, but it should be. We had so much. Let me try to recall what we have in the Francophone side that could be interesting. Some patients were asking also if you have very low blood sugar, but you are able to treat yourself, is that a severe hypoglycemia? The answer is no. But if you have very low blood sugar, like below the level of detection of your glucose sensor, and that you are still able to do this with very mild symptoms, this probably means that you are at high risk of a severe hypoglycemic episode. and that you try to prevent hypoglycemia, to prevent them. There was also a lot of questions about how do we get back those very unpleasant but useful symptoms. It's really no hypoglycemia for at least 2 months that should happen. And there are an ongoing trial in my research center, and I must disclose that I am the researcher trying to see this, if we can do this rather than in-person regular visit, to do this online, and also to test if some specific type of exercise could help. We are looking for a patient. There is no obligation. Okay, how do stress hormones and growth hormones affect hypoglycemia? So actually, we have 3 lines of defense in terms of hormones to hypoglycemia. The first one is actually secreting adrenaline or glucagon. They are very close, the two of them. Adrenaline is a hormone you have when you had a big stress and you have heart palpitation, sweating. That's a hormone you can feel. And glucagon is also, it's the neighbor of insulin cells. It's the alpha cell in the islets that produce glucagon. The bad news in type 1 diabetes is that glucagon don't react well to hypoglycemia, a bit because the beta cells, the one that produce insulin, are not in good health, and seems that the alpha cells are not able to make their good job. So people living with type 1 are mostly relying on type 1 on adrenaline as line of defense. There are other lines, but that comes far later in terms, for example, as it was suggested here, as growth hormone, but it comes too late to really help someone to get out of hypoglycemia rapidly. So it will act during the night if you don't have this, but it won't be on the long dose. When the microdose glucagon be available to the public, it's awaited to be available in the US shortly, or it might already be, but it's usually, it is at least 2 years later in Canada. So we will have to wait sometimes to get this in Canada. How is nosebleed common in patients with serious flow? It can happen, actually. I don't have the good numbers on frequency. I know it can happen. I would not be able to give you a good percentage. Do you know if biosimilar will be available with pens that record last dose? So what we call intelligent pens. We await some announcement of at least one company shortly. The problem is that the pens, the most advanced, are not compatible with the biosimilar pens. So it was supposed to be available last July, and it's constantly postponed. So it's not far, but we don't know exactly when it was. And the person was referring that there was at least one pen recalling the last dose. It can be very useful to just remember if you have, did I inject, yes or no? You don't want to re-inject the second time, and so on. How can we do exercise when I can have, how can we do exercise? We can have a hypo often after. It's possible to prevent hypoglycemia. So hypoglycemia can occur during physical activity, but also for numerous hours after. So it's really, there's a lot of strategies that can help to prevent this. It is roughly to reduce the insulin dose after hypoglycemia. It's working with most long-acting insulin, but not all. For example, Tresiba, the usefulness of reducing it is very low. Or with pump, you can have a temporary basal from the time you go to bed to 3 a.m. or to eat more snack. We are about to open the result of a study that we made where we compared a strategy mostly based on reducing insulin or mostly based on snack. I don't have the results yet about this. There is a lot of program, and actually in the support platform, all the modules to try to prevent hypoglycemia during and after physical activity associated with physical activity are modules that are extremely attended. So I guess that kind of thing is really useful for this. And good evening, Patricia. We've met on a few occasions. So we are close to the end of the webinar now. And if there is no additional question, I want to thank you for attending. We were a bit less in from the Anglophone part, but this is normal. But we know that when it's going on YouTube, there is quite a lot of views after that. We appreciate. And once again, all of this that we present is mostly coming from patients that help us to co-develop this. And I just want to finish by showing the very last slide that I have, if I am able to pass it. that, for example, we have all those tools that were developed, and when you scan the QR code, but it's also on the Type 1 Better site, and Sarah, our excellent nurse which is helping us, is also highly active on social networks to provide tools for patients to prevent more efficiently hypoglycemic episode and better treat the residual episode. We really thank you a lot. I'm just checking there is no additional question. No. So thank you very much for attending tonight's webinar, and we hope we are doing things that you can find helpful. And we want to thank you again for the one that participate to the Better Registry, no obligation, but the more we are, the more representative results we have, we will have, and the more we will be able not only to make science, but also to discuss with payers. And I can tell you in Quebec that the Minister des Services Santé et Services Sociaux is actually looking a lot to what we are doing. Thank you very much, and have a good evening.